this panel is to discuss how we can drive digital health adoption in India, powered by ABDM. I just wanted to give a couple of facts for us to know. As per our estimates, along with the study we did with Nat Health, India already has around 400 million digital health users. That actually makes us the largest user base of digital health users amongst all nations. So India is already a leader in digital health. So this is something to note. There are 4 use cases which have driven digital health adoption. First has been e-pharmacy, which is created by all the startups here in Bangalore, 1mg, PharmEasy, and a bunch of startups. Second is actually teleconsultation, which has also been innovated out of Bangalore. The third is at-home testing for diagnostics, starting with COVID and then later with pathology. There are roughly around 50 million users who are using it today. And finally, wearables. So the objective of today's panel is to problem solve and debate on how can we take this base of 400 million users to over the full adult population of India, which is 1 billion users, and also deepen the penetration of other services and other technology-enabled services which are at the heart of patient centricity. We have a diverse panel from both the provider industry, the solution technology players, as well as an investor on the panel. And I will get us started immediately with a question to you, Dilip. First, if you look at your experience as the leader of India's second largest private hospital chain, what has been the biggest digital health transformation you've seen over the last 5 years, and what has contributed to the transformation?
Thank you, Barnik. And before I start, let me thank both NHA and NASSCOM for inviting me to be here. And thank you, Dr. Sharma, for that. The biggest change that I would have noted in the last couple of years is not really about the technology. I think that followed. The largest change has been in the mindset of people, mindset of our customers. I think traditionally the Indian patients were never the ones that looked at digital as an option for doctor consultation. I think as a country, we wanted to be touched and prodded by our doctors and, touched and felt by people. So I think the biggest shift that we saw as a provider in the last 2 years been the willingness to consider digital as an option for consultation. To give an example, Manipal, like you said, the second largest chain of hospitals in the country. Before COVID, we used to see about less than 1% of our OPD patients through a digital mode, a video consultation mode. In the peak of COVID, it grew to about 35% of all our patients came on the digital channel. And while it has gone back, I think now that everything has opened up, it has gone down to about 6 or 7%. But the move from 1% to 6%, we think is a sustainable move. And I think that is maybe a mindset that we would have changed. That I think the technology team like Kala and Manish and everybody has followed it up with enabling that behavior by creating apps or creating other kind of infrastructure to enable that. Just 2 quick points, Barnik. We also saw in the last 2 years a lot of peer-to-peer collaboration. The Honorable Minister just talked about Manipal working with the government to running tele-ICUs in Karnataka, which reduce mortality. I think we never seen that in the past, that kind of a collaboration. The final thing I would want to say is the collaboration in the ecosystem. Hospitals, insurance companies, TPAs, pharmaceuticals, device manufacturers, all coming together and using digital as a backbone. I think that also has been a development in the last couple of years. So these are 2 or 3 areas where we have seen a change in the last.
Thank you, Dilip. Moving to you, Kala. Can you talk about your experience with the extent of digital healthcare penetration in India, and what have been some of the real success stories you've seen from your organization in adoption of solutions?
Okay, thank you for this. And by the way, I would like to thank NASSCOM and then also NHA. Very happy to be sitting next to you, Dr. Sharma. So thank you very much. So let me start with some statistics. So if you look at India, we are ranked 32nd in the digital adoption index, and there is a 90% growth in the last 3 years. If you have to get into the largest growing digital economy, 17 of them, we rank about the 2nd place. And also in the previous session, we heard we have 1.3 billion digital identity users within India. Now, globally, we have about 45 million patients who are monitored remotely through our digital, I would say, avenues. This includes the IoT, the wearables, etc. I think many of us have that. Now, this is going to move up to 115 million by 2026. And in this movement, India and China are going to play a very, very big role because we have high demand for personalized healthcare. And also there is a lot of deficit, okay, within the demand and the supply gaps, which was brought out, right, by all of you. Now, if I look at the digital penetration, when we talk about that, we heard all of us speaking about the telehealth, which includes the teleconsultation, the telepharmacies, and many other healthcare informatics, analytics, and also the personal health management. Okay, among the unicorns, like, before going into Philips itself, among the unicorns, I'm very happy. I get very inspired by our Portias, the Empine, Eka Care. All of them are really looking towards how to improve the virtual connects and really bring in that digital empathy, because that's what is very important. As Dilip mentioned, it is about the mindset change. It is about making the patients comfortable, because even in my case, I feel much more comfortable going through the digital avenues rather than being present face to face, right? COVID has taught us. So given all these things, I think there is a huge mindset change which has happened. And there is an enablement of digital, especially with India emerging as one of the biggest players when it comes to digital capabilities. I think we have made the shift. Now, I talked about all the examples. Just to share one example, whatever was touched by honorable ministers and then Dr. You also, is about the ICU. This is a small success story from Philips Innovation Campus. We have been there for last 25 years, right? And we came up with this virtual ICU, remote ICU. And with the support of partners like Dilip and all the Apollos, Cloud9, etc., we have been able to bring the solution to life and able to cater to 3,000 beds, ICU beds, okay? And there are papers which are published around this. And we have been able to see the outcomes, because finally we can do all these things. What matters is the outcome. So we have seen there is a drastic reduction in the antibiotics, because many a times it is the first step which is taken, especially when there is no interoperability, etc. So these are some of the examples, and we are set to make the difference to India, because finally it is moving from product to solutions where you understand the customer better, understand the pain points, and then bring in the technology to make the difference.
Thank you, Kala. Coming to Manish, given your vantage point as a global life sciences solution provider, how do you describe what you're seeing in India in terms of digital healthcare versus a few other geographies you and your organization serve?
Sure, thanks, Barnik. First of all, once again, thank you to NASSCOM NHA for inviting me to this panel today. I'm really delighted to be over here. Before I talk about my vantage point of being a global healthcare technology provider, let me talk about another vantage point of having seen evolution of healthcare and technology for more than 2 decades now. I along with a few others started Indegene more than 23 years back, with the whole idea of bringing healthcare and expertise, medical expertise with technology expertise. We started off in Koramangala. And as you can imagine, right, that's the time, I would say even at that point of time, there were people open to adopting technology, right? We developed databases on Palm Pilots. I was joking about in the morning, on phones. I have a colleague of mine who's a doctor himself, who ran the first CME online, continuing medical education for physicians. We co-opted television to do CMEs in India. And there was huge amount of openness to do a lot of this stuff, even way back in the early 2000s, which will be very surprising to us. Obviously, technology was not as evolved as it is today, right? And standards were not evolved. That has changed drastically. So today, we clearly see technology being openness on people, which is true. We just heard about UPI adoption, UID adoption, so many things, how they're taking off in India. And healthcare is not going to be any different, right? Given the scarcity of resources, physicians, hospitals, bunch of other things, healthcare adoption is, technology adoption is increasing. Some of you spoke about the numbers, and there will be a large opportunity. I think the questions to really ask at this point in time, given where we stand, is one, how do we really increase adoption of technology with providers in the care setting very rapidly over the next few years to deliver better access and also better quality. Mind you, that's very important. How do you do this in a sustainable way, right? Unlike UPI, cabs, commerce, we are dealing with human lives and you can't afford mishaps. So how do you do it in a sustainable way? The third and foremost, also a very important question, and that's what we see on the global side happening today, and I think India can really leapfrog over there, is adding truly value-added services which can really leapfrog India to a much more product-driven economy, as Dr. Sharma said, not only just on the technology side, but on the therapeutic side. Right? There is so much going on. Today, we see a lot of application of things like real-world data, real-world evidence coming from all the data which is being generated on the medical side to design products on the therapeutic side, to do clinical trials much better, design protocols in the first place, understand patient journeys, and then hence decide where to intervene from a medical perspective. And in India, given all we are starting today, I think we are at a real advantage of learning from mistakes a lot of people have made and create a stack, and which we are doing, of course, which can really help leapfrog India to a very different scale in terms of not getting the basics only right, but also having a lot of value-added services which can help us move to an innovation-driven economy and or a product-driven economy, as Sharma said earlier.
Thank you, Manish. I'd like to get Hari in on the other side of the story, which is the payer side. India is one of the most under-penetrated markets for health insurance. What are some ideas or challenges and then ideas you have for scaling up health insurance adoption in India using digital tools? It will be louder.
Yes. The mic.
That's it. Yeah. Thanks again to the NHA NASSCOM partnership for pulling together this conversation very timely. And thanks a lot to Dr. Sharma and Dr. Gedam for your leadership of this truly transformational initiative. And I think COVID has served as a bit of a force multiplier and maybe potentially helping drive an inflection point for the adoption of digital technologies. Now, on insurance, actually, I'd say it's not as bad as the stats might call it out to be, because most of the insurance coverage numbers are pre-COVID. It'll be important to see what's happened post, because one is PMJ itself. A lot of the stats on India were pre-PMJ. And I think between PMJ, ESIC, and CGHS, you actually now have 800 million Indians who have some form of coverage. Now, obviously, that still does not cover everyone, and so there is a gap. But the numbers are not as dismal as they might have been, even 3-4 years ago. Now, what we need to do in terms of further increasing, I would say, the quality of coverage is, to get people to better understand and use the existing coverage that they have. For example, with ESIC, many people pay into that coverage pool, but utilization is fairly low. I think there is an opportunity to look at some specific pilots, maybe at the state level, where you try and consolidate the different insurance schemes to reduce overlap, increase funding efficiency, because a lot of this money comes from the government, and in the case of ESIC, also the private sector, to maximize coverage. The second, I think, the government has been looking at this, and there is an ongoing conversation. Could PMJ actually be opened up and made truly universal? Maybe you need to have a sharper set of benefits that are offered to people who are not, the 40% of the poorest population. So for a contained set of coverage conditions, and then with the opportunity of buying top up. So that then becomes a way for more and more Indians to actually get onboarded into PMJ. There is a lot of value in not having a dichotomous insurance ecosystem where, you have the PMJ for the poor and then, other coverage services for people who can pay. I think the more convergence can be managed, I think that's going to lift all boats and actually increase quality across the board. And the third one, I'd say, which is really to get more and more private sector participation. Can the government look at, and I know Dr. Sharma and his team are absolutely doing that, but create ways where participation in the PMJ ecosystem and enabling health insurance coverage actually leads to positive multipliers, whether incentives that enable faster payments, maybe in some cases even higher benefit care packages if you're part of the digital ecosystem, so that it reduces friction and it creates more positive noise around the importance of getting into this digital health ecosystem. I think this is a multi-year and I'd say a multi-decade journey. It's very important that we focus not just on the insurance coverage part, because that could easily take us in the direction of the US, and that's obviously not where we want to go, which is why I think a focus on the PMJ, the Ayushman Bharat's other original arm, health and wellness centers, and strengthening primary care also remains critical. I know there is a contentious internal debate in India at this point about, should insurance also be expanded for OPD, including through PMJ. I don't know where we will land on that. That's obviously going to be a decision for the government of India. But I think we need to figure ways to incentivize preventive and promotive care and not just offer inpatient packages, because otherwise we will face the challenges that other countries like the US and more recently Indonesia are facing, where the government will just not have enough money to pay for people coming into hospitals. So I think lots of great progress, lots of interesting structural questions to solve for, and I think over the next few years the partnership between government, private sector, and I would say the policy ecosystem will help take us in the right direction. Thank you.
Thanks, Adi. I'd like to bring Sunil in now, and I'll ask the question in two parts. You enjoy the unique position of funding healthcare in India, having funded several private hospital chains and also a health tech investor. What do you see are some of the unique opportunities and challenges for providers? And most notably, can digital health be the solution for increasing healthcare access in tier 2, 3, 4 towns where we have very little penetration of hospitals and tertiary care?
Thank you, Barnik. And first of all, thanks to NASSCOM and NHA to put together this program. We need many such programs to encourage entrepreneurs and investors and other stakeholders to come together and solve for what we need for this country. I'll respond, from the third point or the third question that you asked, Barnik. Certainly, digital healthcare is the solution to sort of manage the entire gap that we have in terms of access, affordability, and quality, especially when we get to tier 2, tier 3, tier 4 cities. So there is no doubt about it. If you have to solve for this kind of a population set, with the advantage that we have on the supply side in terms of talent, in terms of our understanding of technology, and some successes which Dr. Sharma mentioned about in the morning, I don't think we have any other way to solve than with digital healthcare. Talking about the challenges, and then I'll come to the opportunity. As an investor, we see quite a few challenges. So today, if you just look at the data point, we have about 8,500 healthcare or health tech startups in the country. Every year, we're adding about 500 to 600. But if you see, there are only few modules which have been successful. So you have e-pharmacy, you have doctor appointment, some telemedicine, teleconsult platforms. So there are only few modules that are successful. So why are the other 70-80% not successful? I think the big challenge that we see here is adoption by all the stakeholders, be it the consumer, patients, be it hospitals, or be it clinicians, who are big enablers. While we saw this percentage of adoption, as Dilip mentioned, go up quite a bit during COVID, it suddenly came down. And now, obviously, we are settling at that 7, 10, 12% kind of a number. It varies. But then we have a long way to go. More importantly, the adoption beyond urban, which is extra urban and rural, is very, very shallow. And for us, if we have to solve for the healthcare, we have to look beyond urban. Sometimes we get a bit parochial because we stay in an environment where most of us use smartphones, most of us use our user behavior and pattern is sort of similar, which is we are used to buying things online, e-pharmacy and all, telemedicine, teleconsult. So we believe that, the adoption is going up. But if you go beyond the urban centers, we feel that it's very, very shallow. So adoption is one big challenge. The second is the focus around enablers. India for the longest time will remain a phygital ecosystem. It won't go digital. So you need enablers which are more physical. So how do you sort of create modules to enable those physical enablers so that you can ultimately reach to this last mile and create that benefit of ecosystem? So that's the second biggest challenge that we see. In terms of, the other challenge that we come across is while, and it's a bit paradoxical, we have the best of the software talent, but most of them are catering to the global markets. When we talk about HIS and Dilip, who's the most experienced on the stage, will vouch for it. And especially when we look for HIS, for tier 2, tier 3 cities, we struggle to get one software which can work really well. And it's so difficult. Now hospitals, when they ask us, can you sort of suggest one good HIS that can work seamlessly? The answer is no. You see which is the one which is most comfortable for the hospital and go ahead and select it. So while we may think that we have the best of the talent, the talent pool that is dedicated towards solving for the domestic market is still a bit shallow. Leave alone the quality of product. So there we certainly need to work, and we have that advantage, but we just need to focus on that. So these are some of the big challenges that we see, and it could also be because, unlike Western market where there is an incentivization, incentivization in different forms to enable adoption. In India, we're still sort of getting there. India underwriting capability is not so much where, somebody who manages health better will have lower underwriting or premium as against somebody who's not managing health. It's about to come, with whatever we are now discussing in the ecosystem. It's just a matter of few years, but today it is sort of absent. So these are some of the challenges. Opportunity immense opportunity, and we see that penetrating and percolating down in the entire ecosystem through many stakeholders. If I just talk about the three main stakeholders, providers, the first and foremost is navigation. If we start using navigation, and the point that Dilip was making, that OPD teleconsult went up to 30-35%. If we are able to sort of create a similar situation in a normal environment, we are taking the load off the hospital. Hospital is there to sort of take care of the tertiary care, secondary care. Primary care can be taken off. That helps all the stakeholders: convenience for patients, convenience for doctors, convenience and asset management for hospitals. They don't have to sort of load up cost just to manage OPD patients. So navigation is the biggest opportunity. If hospitals can adopt, will help. Second is the supply chain. There is significant amount of wastage in the entire healthcare industry just because we are not using digital technology. We've invested in quite a few companies that are looking at supply chain. Immense. In the US, if I just talk about the data point, there is about $500 billion of healthcare wastage. That is because of inefficiency in supply chain. That percentage will certainly be higher in India. So that's the second biggest advantage that the providers will get. And obviously the patient experience increases by all of this. And more importantly, the cost of servicing goes down. If you manage workflow through digital technology, if you manage patient flow navigation through digital technology and supply chain, the cost of servicing patient goes down. If I talk about the second important stakeholder, which is the clinician, again, now clinicians, especially the younger generation, they are realizing the importance of having very positive patient feedback. Now, if you start managing the patient, there are quite a few. In fact, if you look at the entire care pathway, the early part of the care pathway can be managed through digital means. More importantly, chronic disease can be significantly managed with digital technology, digital therapy. So now doctors are realizing how important it is to use these technology, also to manage their own workload, get good feedback. The second thing is the augmentation. Their own clinical capability gets augmented if they use the right technology, in terms of diagnosis to provide the right prescription. So that's the second big advantage that the clinicians get. The third and the most important stakeholder, the patient or the consumer, again, quite a few opportunities. So anything that solves for convenience, that solves for scale leading to low cost, that solves for patients getting care at home. These are big areas that one could look at in terms of opportunity. where patients are ready to pay just because they get the right set of, right prescription, convenience and cost. So these are some of the areas which I believe are good opportunities.
Yes, so just following up on your point, Dilip, I'll come back to you. Manipal Group recently has created like a one patient ID system across your entire group. I wanted to reflect on your experience of rolling out things like HIS, EMR, electronic medical records, right? And other solutions, right? And what's been the experience? What has driven success? And most importantly, how do you make your doctors and nurses more digitally literate? Because that's the service provider where the cutting edge or the front end of the digital experience is.
Yeah. So Barnik, I will deal with that second part first, that the decision on implementing an HMIS. I think it is important for us to realize that bulk of India's private healthcare is fragmented among the 30, 40, 50, 100-bedded small hospitals. It is not hospitals like Manipal or similar corporate chains. And for many of them, investing in an HMIS is a financial decision that, it is like Sunil mentioned earlier that, it's an expensive proposition for a small hospital. And maybe a thought is that the point that Dr. Sharma made earlier in his speech, that is there an option for a software as a service for smaller hospitals to plug in and use, a central HIS, which is developed by somebody like an ABDM team, so that, a lot of the things are already taken care of. The second challenge, apart from the financial decision, because for a hospital, there are always pulls and pressures on where the money goes, whether it is in putting in an HMIS or buying 10 ventilators, that's a call that hospital managers have to take. So that's the first challenge. The second one is to ensure that the doctors and nurses are using it. It is one thing to invest in a high-end technology. The second one is to ensure that people use it to, make it productive. So the challenge is to, when we customize it for a process flow of a hospital, it is easier when you start a greenfield hospital. The team is new. There are no baggage, no legacy. You are starting from scratch, and you could put in a system. But if you want to implement it in a functioning hospital, getting the behavior oriented is the biggest challenge. A doctor who's used to writing a prescription with a pen and paper, would when you tell him, even if a standard order set is available, that everything is on an iPad or a tab, it is always a little hesitation to change the behavior. I think that's the second challenge. Now, to talk about our experience, we took several years, 4 or 5 years of work to implement a system. Again, to Sunil's point, nothing was available in India. We resorted to a US system. And there, what we've been able to do in Manipal is, any patient going to any of our hospitals, the data is available against that ID, whether a patient approaches a Manipal Delhi or a Manipal Vijayawada, the data of the past, including lab and imaging and everything, is available. The issues now that we have acquired some more hospitals to convert everything to the same platform so that people have the benefit. So it is a costly exercise. It is a time-consuming exercise. And, that is something we have a fabulous team, driving this ABDM initiative, almost with missionary zeal. But I think this is a massive task they have in hand when they look at the larger ecosystem of it.
Cool. I'll just get to some solutions and recommendations now. Over to you, Kala. Are there any global innovations which make you excited and could be used in India? And what would you suggest as 1 or 2 actions the government should take to drive more digital adoption of healthcare in India?
Okay, I would like to allude to the previous point, what Dilip mentioned. One of the things is we can always use a global solution and then try to make it work for India. But in my experience, it has been a very, very hard path. What makes sense is to really understand what is the pain point in India. What are we trying to tackle? And in fact, if you look at from a Philips perspective, we have started a very focused approach in the market innovation, where we work with the local ecosystem, where we'll work with the local providers. In order to go deep, we have co-create sessions where we go into deep and understand those problems and then come up with the solutions. Of course, there is part, like, for instance, the platforms that we create, okay, that can be reusable. And also we have groups which are looking into interoperability. This came up very, very loudly previously. And we are working with NHS, right, your group, sir, in order to see how we can share our knowledge that we have got in the last 25 years. From my perspective, if you look at the global solutions, there are teleconsulting, there are a lot of solutions for that. And then ICU, radiology solutions, okay? This is for all the things which we are going through. And when it comes to NCDs, right, the diabetes, and then we are the capital when it comes to the CVDs, right? So we are trying to come up with a solution for that, which is much more appropriate for India. This needs connection with the patients, making them much more trusting to what we are doing, and also looking at all the AI models and the data, which is important, okay? How can we curate this data, come up with the models, which is going to help the physicians to take the timely decisions, the confident decisions. All in all, it is all about, like, reference the global solutions. Of course, we have been catering. Philips has been there for 130 years. Reference those, but really look at the problem, co-create with the ecosystems, and then use the experience that you have had to come up with the solutions. My only request to NHA is, please trust us and then join hands with us. There has been some things which is happening in the last 2 years, but there is an opportunity for us to accelerate this. India is at the right point. We have, in fact, if you look at Philips Innovation Campus, I'm talking about Philips because I work for Philips. So we are the strategic innovation hubs, and 50% for the software for the whole of Philips goes out of here. 80% of the platforms, which is extremely important for the solutions, goes out of here. And we work with local markets. So this is, and also we work with you very, very extensively, and some of the people who are sitting here. So my plea is, let us join hands. It is an ecosystem play, and it's the partnership, and we have the right startups. So join hands, create that urgency, and then let us be very specific, create these fusion teams with a singular purpose to drive towards the solution.
Cool. Thank you, Kala. Manish, asking you to weigh in, what are some relevant learnings you have from other markets which can be applied to India, and any policy prescriptions for NHA or the government to drive adoption?
Sure. Let me start with the more recent things I've observed. I don't know how many of you have been to HIMSS, one of the largest health IT conference in the United States. I used to go there till a few years back pre-COVID, and it's a massive conference, right? On the lighter side, I used to, just seeing the stalls, I would do my 10,000 steps in a day. And a very significant portion of that was dedicated towards interoperability. Number of people trying to solve interoperability problems, which was coming in the way of solving some of the more value-added stuff, which I just spoke about, real-world data, understanding patient journeys, integrated. It was an issue. Now, I think that's something which we have embarked on a journey where we would be leading the world, right? That's a great thing. The entire stack we heard about in the morning, that's something which the West struggled with for a very, very long period of time and wasted a lot of time. With that, let me just do a flashback. We started working in the United States in 2005. And first thing we had done is acquired a health tech company focused on life sciences, which is where we are domain. The reality is that that time, the United States also was struggling from a digital perspective. And we went and told our clients, you can do this with technology. There was some bit of reluctance. The two use cases we found, and which were scalable, could be monetized, could have built a profitable model around that. One was training reps using technology in context of medical stuff, right? How do you get a rep who's going to visit an oncologist or a cardiologist to really understand the practice well, right? So simulations of that using medical data, clinical data, and virtual stuff. The second was training physicians themselves, right? Creating oncology clinics, cardiology clinics in a virtual world, backed up by a huge amount of medical data. Those are very few cases. And this is the time in 2008 or so, from what I remember, the adoption of medical records, even in the United States, when you had a lot of companies in that space, was 3% or so. There are few things which changed, right? And at least our part of the world, which was the life sciences space. One was US came up with this Sunshine Act, where any interaction with physician above a certain level, and it was pretty low, it was $100, $1,000, you got to declare that. The second, and what that enabled is pharma companies start thinking about digital workflows to make sure that they have the traceability, they know what's going on, and a very significant amount of automation started happening in that space, an adoption of technology happening just because of that one regulation. The other thing which happened was the High Tech Act in 2009, which President Obama announced, right? Which was meaningful use of technology and data. If you can demonstrate as a practice, there are incentives, right? Significant incentives to adopt technology. That led to increase in adoption from 3% or so I spoke about to close to or slightly above 90%, even in 2017. That became the bedrock on which obviously a lot of these value-added applications or value-based healthcare, a lot of the other things which I spoke about, right, really started building upon. So that's one side on the incentives to the industry, and we don't necessarily have to do what was done in the US. Our context is very different, but there might be innovative ways to provide incentives to the healthcare industry. That's one thing which we at least saw happening, which drastically changed the industry. The second thing, again, which I believe you can learn on is apart from the tech stack, which is obviously very important in healthcare, what we saw is parallel adoption of medical standards. We heard some people talking about protocols of care, right? To make sure that the probability of mishaps happening are very low. We have Dilip, I spoke about early 2000 working in the Indian context. We worked with a lot of doctors in Manipal itself and many other hospitals across eminent hospitals and doctors in India saying that how should a particular disease be treated, right? Driving consensus around that and giving some more sanctity to those standards, which reduce the risk of adoption and hence records being created. So that parallel track is what we saw countries do well and hence took out some of the risk in the system, right, from a healthcare perspective and drive much more standardization from a care perspective as well. So those will be few of the learnings I would call upon.
Thank you, Manish. Hari, over to you. Any big policy, law amendments or changes you would advocate for to drive digital adoption?
No, I think Manish has actually covered a lot of the points. And I think, frankly, in India, the gaps are not usually to do with policy, it's really with practice. And I think we have a good enough enabling policy environment at this point. Obviously, the adoption of the data protection bill, whenever that happens, will be important because I think, you know, the final addition is really giving patients the sense that they own their data. I think that's a really important one shift we have to move towards, where consent and data ownership is with patients and not necessarily with healthcare providers. Currently, the balance of power is very much with, you know, the hospitals and the healthcare providers, and that has to be inverted because, as Dr. Sharma said, I think India has embarked on a vision of, you know, not, you know, allowing monopolies or not allowing, you know, capture by one or two large players. And it's really about creating an ecosystem where, you know, everyone is a winner as opposed to the winner takes all. So I think the approach to get there, in my view, is not so much through punitive policy as much as it is about positive incentives for adoption. I think we need to look at ways that we can bring, to Dilip's point, the smaller, less organized players on board. I think there is sometimes a tendency to fixate on the big hospitals and, you know, focus on how do you get them to play ball. But I think the bigger question in a place like India is how can you get the labs, you know, the PHCs, the small clinics with the GPs to start entering data into systems. Now, that's obviously not going to happen because doctors, you know, don't have the time. So can we come up, and that's where, you know, with India's technology prowess, to me, the answer is yes, but can we come up with, you know, innovative tools to take data entry down to, you know, the most logical level? Can we create, you know, speech based tools, voice based tools, including in the vernacular where patients can start to self-populate data? And then what you need is really reliability checks. Can you create, you know, again, to a point Dr. Sharma had made and Dilip brought up, reference platforms, you know, whether it's a HIS, whether it's a lab based information system, to enable the mom and pop shops to be able to adopt, maybe in a SaaS mode, enter data. So anytime you actually move up the value chain, you know, to secondary and tertiary, you have all the data that is needed. So can you get the front lines to really start doing this better? And to me, that's a question of coming up with the right kinds of incentives and not really a matter of, you know, policy and regulatory frameworks. There is one area where I think maybe IRDA and NHA working together would be helpful, maybe to create an empaneled set of digital healthcare systems providers. So, the reliability questions that Sunil and Dilip talked about can be addressed. If those empaneled providers are in ABDM compliant, then, anyone knows that by signing up with so-and-so person, I am actually getting a good product, and the data that I enter into the system will also help take care of my compliance needs. So I think that kind of an added ecosystem intervention might make sense. I have every confidence that we are actually on the pathway to getting there, and it's really one step at a time. So let's keep doing this the right way. I think the direction setting from the NHA is spot on, and I think in 5 years, we'll have this going. A last point, I think, particularly for the role of philanthropies and foundations, maybe there is space for something of an adoption alliance to be created, because I think working with these individual service providers, disaggregated entities, requires all systems, all hands on deck approach that has to cover all of India. So maybe, looking at ways to bring in, corporate foundations, philanthropic foundations, maybe even individual givers, building on the lessons that we had from COVID, where all of India contributed to the national response. Can we create maybe district focused funds to get individual, labs and players and clinics onboarded through a mix of, obviously making available technology solutions, but maybe even supporting a sales force of sorts, feet on the ground, because this is going to be a fundamental shift in provider behavior. So you might need a 1 or 2 year, onboarding ramp where people have support so they get the system right. Because at the first sign of trouble, people are going to say, "Oh, kaam nahi karta hai, we have to get out of this," right? So this is a fundamental behavior change. I think that has to be supported on the ground, not just through the technology, but also enabling, human support. So those are a set of thoughts. Thank you.
Thanks, Hari. Just picking up one of your threads. I think India has around 10 to 11 lakh private hospital beds. I think providers like Dilip and Apollo and others contribute to less than 1 lakh of it. So there are around 9-10 lakh beds which are completely fragmented, right? So I know Dr. Gedam was talking of 500 integrations. I think India may need 50,000 or 100,000 integrations to cover the ecosystem. So Dilip, any thoughts on how can we get ABDM to the last mile of healthcare providers?
I think, like we discussed this morning, Barnik, that I think the challenge is exactly what Dr. Gedam talked about in his speech, that we have 19 lakh beds, and out of that, about 12 lakhs is the private sector. The second largest, Dr. Gedam, is Manipal, which is just 7,600 beds out of that 12 lakh private bed. So if you add all the large corporate chains, Dr. Sharma, it will come to about 50,000 beds. You add every cities, large private hospital, the cities, we come to about 1 lakh of beds, 1.5 lakh beds. So like I mentioned earlier, the rest of the India is the 30, 40, 50 bedded, small hospitals. And I just want to share one more, data point. India does about 400 crore OPD consultations in a year. An average Indian consults a doctor 3.5 times a year, so 400 crore. Manipal does 40 lakhs out of that. That's the proportion. So I think we need to capture the small guys, the small hospital in Orissa, in West Bengal, in Rajasthan, in Tamil Nadu, and the 30, 40, 50 bedded hospitals, where usually you have one doctor, at the most 2 doctors, 2 or 3 trained nurses, and rest are, support workers which are there. They would need to see the benefits of joining ABDM. I think it is not about forcing them to join ABDM. I think they would, then we might get a technical collaboration, but not a collaboration in the spirit. I think it's about working with them, making them realize the advantages of being part of this large platform. And like I mentioned earlier, Dr. Sharma, Dr. Gedam, that, you have a wonderful team, but I would only say you have a journey ahead of you. I don't think it will happen in the next 1 or 2 years. I think you have a journey ahead of you, and we have to work together to make the smaller hospitals, that single doctor, the 3 nurses, realize what ABDM would make mean for them, how it would ease their lives. I think that ought to be the communication. Like Hari mentioned earlier, I think the communication from a tech angle would need to possibly focus a little bit more on the benefits that they would derive out of ABDM. And maybe that is a concerted effort. It can't be only with NHA or ABDM doing this. It has to be a collective effort. The way Aadhaar was promoted by everybody, the way COVID was promoted by everybody, it has to be a national effort. And my request is that, we do it as a collective, as a nation, to get everybody alive. That's how I
Thank
would
you,
say.
Dilip. Sunil, final word, top 2 or 3 government actions you would seek to drive viability and digital adoption.
I exactly had the 2 points that Dilip mentioned. First of all, it's the onus is on the entire ecosystem to make ABDM successful. Where just like the golden quadrangle, which are connecting the main points. If we have that solid, all of us come together to make it solid, then the peripheral roads will have no option but to be as good as the golden quadrangle. So first and foremost, we need to make it successful. The entire ecosystem will fall into place. So that's the number 1 point. Second point, again, exactly what Dilip mentioned. Skilling is very, very important. You have to strengthen the enablers. At the end of the day, these are the enablers. You cannot have hospitals everywhere. But India, in our view, is going to be for a long time a phygital market. And therefore, the more you enable, the more you skill these healthcare workers, the more benefit that you will see. And the benefit will percolate down to the most important stakeholder, which is my third point, which is the entire consumer patient base. If we talk about the 1.3 billion population, they need to be coached, trained, incentivized. And the more focus we give on skilling, the more focus we give on digitizing the primary healthcare, which takes the biggest sort of load in the entire care pathway, the better we will be in solving each and every problem in healthcare. So these are the 3 big areas that I believe we should focus on.
Yeah, thanks. I think we are done with it. I just want to make one final comment, linking Manish's thoughts on care standards and quality of standards, linking that to incentivizing hospitals to deliver better care of standards, and then using that as a hook for them to adopt digital solutions, maybe a systemic change we can think about. With that, the panel is nearly done. We can open up for 2 or 3 questions. Vikram, if you don't mind, or we have. Yes.
No, I think
At the end, we'll ask Dr. Sharma for his concluding remarks.
I've learned so much in this session, so I don't think I can contribute or add anything to it. And of course, if I start summarizing it, it will take another 15-20 minutes. So I think we have fantastic ideas, I must say.
Any questions? I don't know if there's a mic. Yes. Yeah, 2 questions probably. There's a mic there.
Good morning. My name is Anunay Jain. I represent Japaigo, a not-for-profit that works within the healthcare system. Dr. Sharma, nice to meet you again. Couple of points coming from a slightly different perspective, because we work with the real front lines of healthcare, with the community healthcare workers. We've done some experiments with interoperability, and Hari would know about it because we've done it with the support of the BMGF in Rajasthan, for example. I think one important aspect to consider is how do you really make interoperability real and contextual as far as real practice is concerned, right? We're talking about linking data, linking records to each other, and making all of that data available to the healthcare practitioners themselves. But what are they going to do with it? I think that's one important aspect to start considering as soon as we're starting to talk about this. The other aspect that comes to mind about the adoption of this technology itself. One of the pieces that we fear we're going to land up in, we're firmly in the space of mHealth at this point of time. Just to give you a context, one state in India has about 47 healthcare applications that are run by the National Health Mission at this point of time. As we are getting into it, what's really going to start happening is there's going to be a lot of administrative burden that's going to start coming on towards the physicians, the nurses, and the healthcare providers themselves. One important aspect that I don't think there's been a lot of thought about is how do you really create task shifting from these healthcare providers to scale up some of the lower healthcare providers. I'll give you a very quick example. If you go down to a maternal healthcare camp in any of the states today, what you'll see is that the lowest skilled worker, the ASHA, is actually doing the counseling of the mothers. Whereas the higher trained worker, which is the ANM or the CHO, are actually playing around with digital applications and entering data in it. And so I think that equation needs to start getting reversed. And so very important considerations, both for the supply side economy, which is going to supply all of these applications, as well as from a policy perspective and administrative perspective, on how do you really manage this so that you're really still operating at the top of your license and not relegating healthcare providers to entering data into systems.
Thank you. I think the panel would agree. I think we have to extend healthcare beyond the hospital and broaden the care continuum to include primary and preventive medicine. Any other final question? Again, yeah.
I'm Lakshmi Jagannathan. I run a incubator for healthcare startups. So I think there are all people representing innovation and startups, be it a hospital or a corporate. Having said that, there are opportunities for innovation. The challenges for a healthcare startup are huge, starting from piloting to clinical trials to raising investment for healthcare startups. There are huge. How is this platform going to leverage? How can a startup leverage this platform to cut short his innovation cycle and scale up faster?
No, I think let me try to answer this question. This is precisely what we are trying to do in the Ayushman Bharat Digital Mission, because let's say there are some inbuilt components, so to say. We have built a framework, and not only we have built those technology pieces or tools, what we call the building blocks, we are also building the broad data which is required, which every innovator, if you want to work in the health space, you need to collect some of the data. Like you have to figure out some doctor volunteers, you have to figure out some patient volunteers, stuff like that, just to test the whole thing. Now what is being done is that we are bringing those reference data points. So we have the health facilities registry, the reference, then the health professional registry, then we have drug registry, then we have other kinds of laboratories. Lab registry also is a part of the health facility registry. So essentially the idea is, and we want to learn, we want to really understand if there are other building blocks which we could make, which are common building blocks, which will serve the expediting the startups, so that the startups could just plug and start their journey rather than arranging for everything. So this is the kind of thing which we want to do. It's like a broad house, just a structure has been made. Now you can come in and you can just build your room and connect with the other components of the house. That's the broad way we are working. And in case you have any suggestions to enrich this set of tools or references or anything, we'll be very happy to work with you.
I think, Vikram, we should wrap up. I think we are over time.
So thank you everyone. It was a wonderful discussion, wonderful ideas, and we'll be following up on some of those. I think with that,